Yes, thank you very much. And before we go on to the instruction course, a very good afternoon to all the learned speakers who are with me in this instruction course. Before we go on to the buckling of the retina, I just want to dwell with the history of retinal detachment. I think at this juncture, we must remember the great stalwarts of retinal detachment, that is Jules Gonin. Gonin was born in Lausanne in the year 1870, and in 1902, he was in Lausanne with Professor Marc Dufour. And Marc Dufour, who was the chairman of the Department of Ophthalmology at that time, so he saw a great potential in him, and therefore, after only 2 years, maybe in 1903, he was made chairman of the department. And then, he, went into the research in the retinal diseases area. And he presented the first paper in 1918 in the Swiss Ophthalmology Congress. And he was the one, for the first time, he said that the retinal detachment is caused by the retinal hole. But not many people would agree with him. And he could only be recognized, in somewhere in 1922, when, people got to know that this is because of, retinal hole, the retinal detachment. And, the first, the surgery which he devised for a retinal detachment, that was known as a Agni Puncture. And Agni Puncture was something like he prepared a dithermic needle, and through the needle he will puncture and drain the fluid. Later, the modifications came. Then scleral dithermy was, invented by the Shapland, Linder, and Poffick, and later by Custodies, who started with the sponges and with the skipens, with the the scleral incision, and in the implants, Linkoff with the cryo, and so on and so forth. This is what is the the chronology of events in the development of retinal detachment, and now you can see the vitreoretinal surgery and all. The reason I'm saying here, the younger people may not be knowing about Jules Gonin. And of course, Jules Gonin was awarded a Nobel Prize in the year 1933. Unfortunately, he died and he could not receive the Nobel Prize for his discovery on retinal detachment. Now, the next slide, please. This particular presentation, as you can see here, normally the instruction courses on retinal detachment are, because related to, the routine kind of, the retinal detachments cases and all that. But there are several occasions, like buckling for unusual breaks. There are unusual breaks are there. We did a lot of these cases, earlier. Maybe, younger people may not have seen, we did surgery without microscope retinal detachment surgery. And I can tell you, we used to do it much faster than the other people. And of course, now there is a suprachoroidal buckling, which is used for many of the, for the disease delivery and also for retinal detachments. We have this macular buckling. This has come from Japan, and also there are some people who are doing in China and some part of the Russia. This is being done. And then we have this buckling without peritomy. This is something new, and we'll be hearing the learned speaker. And then buccal revision. I think buccal revision you people may not be knowing. We did a lot of these buccal revisions. If there is one failed retinal detachment, then we have to, revise the buccal, and we will either remove the buccal, or behind this buccal, we'll put another sponge or another buccal and then drain the fluid. That was what was called as a buccal revision earlier times. And then, last but not the least, we must remember management of buccal complications. Of course, this has gone much, much less than what was earlier, because dithermy was done and the sponges were then. The sponges used to act as a depot for the infection, and there used to be a lot of these extrusions and infection following the buccal surgery. So may I have the next one? Can I have the next one? These are small, video of the. Now it's very difficult to do the video for the retinal detachment surgery because you are using the indirect. You are also using the microscope. I thought we'll just, show this. Now earlier we used to do this, limbal, this thing to remove the conjunctiva. You see, this video is so clear. I don't have to tell you anything. Go inside and see the hole, do the cryo, and drain the fluid. And, that is the usual practice which is done now. The cryo has been done. And this, you pass the suture. While passing the suture, then we used to, say that when you are passing the suture, not to go too deep. For that, you must keep seeing the tip of this needle so that you don't go deep and there is no scleral perforation. So these are the points, which one has to remember. I may have the next one. I think that other speakers are there. Please go to the next one. Go to the next one. Yes. So scleral buckling is something, is from age old. This is something was done earlier, and it is definitely an art, and it has got a very important role, especially in VR surgery nowadays. There are certain types of detachments where you need to put the buccal and then go into the vitreous and do the vitreoretinal surgery. And of course, the scleral buckling in many situations, it is the surgery which is the minimum surgery with maximum years. With this, I will ask the next speaker.